Dr. James Madara, we've known each other for a long time, and you are now CEO of the American Medical Association, but you bring to the AMA and to healthcare a unique background in the fact that you were not only a practicing doctor at a large academic medical center, University of Chicago, but you also ran the University of Chicago Medical Center as CEO, I can safe to say a billion-dollar enterprise. And you bring to the AMA a different perspective, having heard you give your speech last summer about, just changes that doctors need to go about in their daily lives. And we have a physician shortage, and people are talking about, going to value-based medical care. If you could tell us a little bit about, I'm sort of intrigued with your talk about how maybe changing the medical school experience, if not shortening the training aspect of that, how that would work and why that's necessary, and then we can also talk about some of the other things.
Well, one of the really interesting things about medical education is that with all the advances in medicine and the curricular updates that occur consequent to that, one thing that has stayed static for a century is the structure of medical school. And so it's very time-based currently rather than competency-based, for example. It is really based on the individual, and yet we practice in teams currently. Mm-hmm. Much of the training that happens clinically is inpatient, but that experience is now dominantly shifted to the outpatient area. Mm-hmm. So the entire structure of medical school, making it competency-based, which may shorten it, and if it shortens, if one can show demonstrated competency in a shorter period of time, also positively affects the student debt aspect that students have to carry now, and is really a drag on medical students that are facing this new world and picking specialties.
How much, and to interrupt, but how much is a doctor's student debt in this day and age? I mean, we're talking, it's like a second mortgage for physicians.
Yeah, on average, students will graduate with debts of $160,000 to $200,000. And it's been demonstrated that it influences how they choose to practice, mm-hmm. Where they choose to practice. We demonstrated when I was at University of Chicago that one could, by relieving debt, greatly influence where students wish to practice ultimately. Mm-hmm. And so this is something at the AMA we're paying a lot of attention to. We will release a request for proposals next month mm-hmm. to medical schools, and we hope to work with a group of 5 to 10 medical schools toward a new structure and have this group of 5 to 10 schools be a learning consortium.
I've had friends in medical school and they say, the fourth year is a waste of time, all I'm doing is applying for residencies and so forth. I mean, is it as simple as that, where I think at the AMA meeting some doctors are saying, well, maybe we could combine the fourth year with the first year, and I mean, is it that simple? Would it need? If I were in a certain state or a certain school, could I just do it, or do you have to get approval from different people?
Right now, schools have very little flexibility one school to the next. There are credentialing standards that have to be met. Certainly, the LCME is the credentialing body. Is trying innovative programs, allowing schools to do innovative things, but on smaller scales in subunits of the school. This is really to try to do what was done by Flexner in the beginning of the 20th century, and that is create a new structure that's updated for the time.
Mm-hmm. Yeah, I think I was just talking to 2 of your mm-hmm. former colleagues at University of Chicago for a post I wrote for Forbes, where they were saying that the educational experience is 2/3 inpatient and 1/3 outpatient, but often the doctor, until some new things they're trying at University of Chicago and other places, where that 1/3 that they spend outpatient in the clinic where people see their doctors isn't just in the clinic. They're getting paged and so forth, and that leads to them not even wanting to go into primary care. Is that what we're talking about here? They have to make it more of a real-life experience?
Yes. So we at the AMA, the AAMC, the IOM, have all made this common observation, just as you've outlined, that the training doesn't really match the reality of the practice. Mm-hmm. And one of the dissatisfiers of people leaving medical school finishing their training and residency and going into practice is the environment they end up in isn't reflective of what they were trained for.
Right, and then that also can lead to other things where, you know, if a physician is constantly spent all of his time training in a hospital, and then they wonder why he takes a job in primary care and then he or she doesn't have a good bedside manner, or they're not used to dealing with insurance companies, and no wonder they're grumpy all day.
Well, one of the things I have to say about our medical students is they're so fabulously bright that they can compensate for the deficiencies of the curriculum that they have.
Yeah.
And we need to really, we owe it to them and are working hard at the AMA to repair that.
That's great. So you also mentioned the AMA is working on some other new efforts.
Yes.
With, you know, it's all about quality and outcomes and sort of changing the way physicians think, and perhaps this could lead to maybe a more positive relationship between, you know, the payer, the insurance company, and the doctor. Tell me a little bit about that.
Well, there are two other pieces. We're looking at outcomes for medical students, as I've just mentioned. We're also looking at outcomes for patients. We will be creating and are about to announce the first two elements of a dashboard of outcomes. We will have a dashboard that's populated by no more than 7 to 10 outcome events. These will be outcomes that cover a large swath of disease for the United States.
Can you give me an example?
So, an example would be cardiovascular disease with outcomes that are measured, and the outcomes would include real outcomes, morbidity, mortality, but also importantly, patient-reported outcomes. When one speaks to patient advocacy groups and patients themselves, they're less interested in some of the measures we do and more interested in whether their pain is relieved, whether they're mobile again, whether they can go back to work and interact in an efficient way and with their family in the way that they're accustomed to. So outcomes that are endpoints of morbidity, mortality, but also patient-reported outcomes will be part of this dashboard, and will establish national targets and work with provider systems to see if we can push this toward a higher value, higher quality health system.
So it could be an outcome if I have a knee replacement, and all I want to know as a patient is, doctor, when am I going to be able to get back on the golf course, or when am I going to be able to get back to work? And so you would be developing a sort of a system that says, like, according to all this expert data, when you go in for a certain procedure, or then this is when you should be back in action, that type of thing?
Yeah, so it would be a blend of medical kinds of outcomes, where in the instance that you're describing, the ability to flex the knee, the strength, et cetera, would be measures. But then there's the critical issue of how the patient feels about it. Mm-hmm. Does the patient feel that there is an improvement that these other data might show or not?
Mm-hmm. Now, would these oftentimes, what physicians don't like is that when they have a set of measures and things that they have to deal with, one insurance company or one employer has different models. Is it the hope that when the AMA creates these and they have input, that they would be adopted by all the insurance companies?
We certainly think that there should be more standardizations, and that would allow for administrative simplification in this system. So, physicians could do what they love to do, and that is take care of their patients, as opposed to dealing with different sets of rules for different payers.
Mm-hmm. And do you, I know that you also, you've been at the AMA less than 2 years, you went out and hired a person that specifically deals with this from Kaiser Permanente, which is known in this area. Could you talk a little bit about that and what that might bring?
Well, that's the third outcome.
Okay.
And this is an outcome for physicians. Okay. And so we've been very active in Washington in advocacy and shaping and contributing to policy as it's forming. But then the question is, how about the longer term view of payment and delivery? The longer term view of payment and delivery is complex because there are so many, as you well know, Bruce, and have written about, so many systems out there. And so we have done the following. We've applied a filter to limit that universe, and then a lens that's AMA specific to look at what's left. And the filter is quality and value. We just don't think systems will remain part of the future if they don't deliver quality and value. And then the lens that's AMA specific is physician satisfaction. Now, patient satisfaction has been well measured for a long time. Physician satisfaction, much less so. The data that's out there suggests, not surprisingly, that satisfied physicians yield satisfied patients. And there are even some hints in data that satisfied physicians produce better outcomes. We are developing tools with RAND Corporation toward this end. And Jay Crossan, who was a senior executive at Kaiser Permanente and a vice chair of MedPAC, has joined us to take the lead in this project. We will be going in within the next year into 30 different practices in 6 different states, developing the tools to measure physician satisfaction, and then going into those places to try to understand the variables that feed into this satisfied state versus not, and then to use those to try to get them embedded in the healthcare system.
And that's interesting because when you look at, borrowing ideas from an outfit like Kaiser, they score very high, with the new ratings that the Medicare program has for health plans. And then if you rate higher, you get more reimbursement. You get better pay from the government for what you're doing. Are there certain areas where you see that are solvable? Could you give us like a real life thing where a physician is not satisfied that might translate into the patient, or,
Well, there have been many things proposed to feed into physician satisfaction, and certainly the administrative support that allows simplification of paperwork, et cetera. But one has to really measure the true outcome, the satisfaction itself, and then work backwards to the variable. And that's the effort that's expended here. One of the interesting things that have come out of early work in physician satisfaction is one of the primary drivers of physician satisfaction is feeling that they have given quality care and have had time to give quality care to their patients. I think that will probably be an important element. And that, stated in that way, is probably something we would all want to engage.